chronic-related metabolic syndrome, or CRMS. So CRMS is one of the more challenging diagnoses, I feel like. It's also known as CF screen positive inconclusive diagnosis, or CF SPID, outside of the U.S. So that may be what you guys call it. But in the U.S., we call it CRMS. It's diagnosed when a newborn has a positive newborn screen result and a sweat chloride test less than 30 and 2 CFTR variants, one or more being classified as CF causing. And we use the CFTR2 website to tell us which mutations are considered CF causing at this point in time. And that's available for everyone. And then, or a sweat chloride that's intermediate 30 to 59, and one or no variants that are classified as CF causing by CFTR2. So this is sort of our flow diagram of how we work through this. So you have a newborn screen result that is positive, and then either you have a normal sweat pointer. Either you have a normal sweat less than 30, or you can have a sweat chloride that's intermediate 30 to 59, or a high sweat greater than or equal to 60, which is clearly CF. But when you have these others, when we have especially this, so when we have the intermediate, the sweat chloride is 30 to 59. If we have one or no CF variants, then this is CRMS or CF SPID. If we have 2 variants, of course, this is CF. When we have a negative here, then we're at sorry. Then we come down here and we end up. I'm working. Sorry. Sorry. Okay. So here we have no CFTR variants. This is CF not suspected. Some have a false positive newborn screen result. Here you have one CF causing variant, your barrier, and if you have 2 CFTR causing variants but a negative sweat test, this again is CRMS or CF SPID. You have 2 CF causing variants, of course, it's CF. Okay, so how do we manage patients once we get to this place? We tend to see them initially when we make that diagnosis of CRMS, and then at 6 months of age, and then at least annually with a sweat chloride through the age of 6, and I think they maybe extend during even 8. At that final visit, you should do again an extensive evaluation for consideration for future management, just in case symptoms arise, and really counseling families. If you release patients from a pulmonologist here at age 6, they recommend consideration to have them return in 10 years during their teenage years when symptoms may begin to present, because some patients in this category of CRMS may transition to be true CF over time. And so that's really the concern of following these patients that fall into this range of not quite CF, really, over time. And at the initial assessment, we get a sweat chloride test, of course, which helps us determine that they do have CRMS. And then there's a recommendation for extended CFTR sequencing, so that we get full genome sequencing. Once resulted, again, if you have 2 variants that are not yet identified, then we can order some add-on testing in our lab, where we look at deletion and duplication testing, and see if those help us elucidate true diagnosis. We do check for updates in CFTR2 because those do change and get updated over time. So each addition, here when we see them back, we can check and make sure that those variants of unknown significance have not become true variants, or the other way, where sometimes they take genes off of that list, right, where they thought they were causing and now decide that they're not. We do a fecal elastase, where we're looking for evidence of pancreatic insufficiency. And we do a CF respiratory culture, looking most specifically for things like pseudomonas that might be more consistent with a true diagnosis of CF. We make sure genetic counseling is done if it wasn't done already. And we do a respiratory assessment, including a history of cough and infections, listening to them, looking at respiratory rate, etc. We do an abdominal assessment, history and exam. We do nutritional assessment, make sure that their growth looks good. Are we seeing concerns there that might push us to think more about CF? An RD visit, a dietitian visit is not required, but should be considered if it's clinically indicated. We do consult our social workers, and our registry follows patients with CRMS as well. Again, trying to learn about what happens with these patients over time. Do they convert to CF? Do they not? Which patients are more likely? So we do consent them to be part of our registry as well. We provide education about tobacco exposure avoidance, because certainly that can be bad for any of these children. We explain to parents what the diagnosis is and what the potential outcomes are, including that they could again eventually transition to CF, so that they're aware and looking for any symptoms and signs of that. We inform the PCP, their primary care doctor, as well about what CRMS is. And again, it's one of the more challenging diagnoses for people who are really understand. Chest imaging is not required, but if there are clinical indications, you're worried, then getting an X-ray is certainly a reasonable starting point. And then CF labs, again, not required for this diagnosis, but if you have suspicions of somebody who may truly have CF or is transitioning to CF, getting those labs can again be helpful to assess whether or not that's occurring. Again, the follow-up, we see them at the initial diagnosis at 6 months of age, and then yearly through age 6. And they should be seen in clinic at a minimum until we have 2 consecutive negative sweat tests. If you have 2 consecutive negative sweat tests, then again, they say you can release them from your care, but we should send a note to their primary care, make sure that we're really counseling families about follow-up if any new symptoms occur. A lot of times we see these kids continue to have indeterminate sweats over time. After age 6, again, follow-up as needed, but again, there's that recommendation for potentially 10 years later in their teenage years. And then in the annual assessment, we do sweat chloride testing each year, looking for any transitions to a true positive or a true negative. We look for updates in the CFTR2 database to see if the genetics have changed at all. We do a CF respiratory culture. We do spirometry when they reach 6 years of age. Sometimes we start it at 5. And then a good respiratory assessment with a good history exam and look at their respiratory rate. A good abdominal assessment, again, nutritional assessments each year, not necessarily with a dietitian, but at least by us as the physicians and a dietitian if indicated. A lot of times our dietitians will see the patients, and that's fine, but it's not a requirement. And then consider also the fecal elastase. We definitely want to do that at 12 months, but consider it for other visits if clinically there's a concern about growth, etc. Chest imaging, again, not required unless you have suspicions of symptoms. Same for labs. So these were the updates in the most recent guidelines that came out for CRMS. And you can see the evidence isn't great when we look at the quality of evidence. A lot of C and D level evidence here because we don't have enough, I think, good data yet long term, and that's part of the reason for following these kids and really learning about what's going on. But I think this recaps a lot of what I've already talked about. And then I'll talk a little bit about CFTR-related disorder, which is different than CRMS. CFTR-related disorder is a clinical entity with CFTR dysfunction that does not fulfill the diagnostic criteria for CF. So remember, CRMS is based on newborn screen results. This is somebody who has a sign, a clinical entity that can be associated with CF and has CFTR dysfunction, but doesn't meet full criteria for CF. So congenital bilateral absence of the vas deferens with CFTR dysfunction. A lot of times this is picked up when people are having infertility issues as adults, and they're working on why they're having troubles having children, and they'll identify that the father has CFTR dysfunction and congenital absence of the vas deferens, and will make this diagnosis if they have no other signs and symptoms of CF. Acute or recurrent chronic pancreatitis with CFTR dysfunction is another area. In my fellowship, I distinctly remember a woman who people thought had chronic pancreatitis because she drank a lot and had alcohol issues, and it turned out that she actually had CFTR dysfunction as well. And then disseminated bronchiectasis with CFTR dysfunction that doesn't otherwise meet criteria of CF are some of those clinical entities that people can have just those isolated things. So again, CRMS or CF-SPID and CFTR-related disorders are actually distinct designations. One is a consequence of the positive newborn screen, and the other really is arising from true clinical features. So infants with CRMS may have an increased risk of developing CFTR-related disorder over time, even if they're remaining healthy during childhood, as variants that are reported with CFTR-related disorder are regularly seen in infants with CRMS. So you may have somebody who has CRMS, who never converts to true CF, but in adulthood actually becomes a CFTR-related disorder. So I think it's important to understand a little bit about the distinctions between these. And I will stop there. Thank you. I think these are really good.
Thank you, Amy, for this really interesting talk. Well, for us, we don't see a lot of CF-related metabolic syndrome, simply because we don't have the newborn screening program. And so we don't anticipate that patients will come in with sweat chloride and then we know that they may have a mutation. Turns out that they don't have the CFTR dysfunction demonstrated by sweat chloride. So basically, I think that if we expand the scope of CF diagnostics to include these patients as well, what would be your recommendation for patients who have this need to get sweat chloride or need to do a mutation?
Yeah, I think without newborn screening, obviously you're not going to have the CRMS or CF-SPID, but what you could see over time is CFTR-related disorder, right? And I think those are more likely to be adults that will be recognized as having one of these clinical entities. And I think at that point, when you see those entities, it's important to think about sweat testing. Just like in kids, sometimes an ENT doctor, doctor will see somebody with nasal polyps, and we always say, think about CF, right? So I think when you see somebody with infertility and congenital absence of the vas deferens, you should get a sweat test to make sure that we haven't missed CF in particular. CFTR-related disorder, there's not particular management guidelines in that way, but I think making sure that we're not missing CF in some people is really important, especially as you know, have more medications, especially tricaptan and things with people. If they had CF, might qualify and it might extend their lives.
And is there like a statistic or something that tells you what's the percentage of CF-SPID that would eventually develop full-blown CF?
I do not know the statistics. Sam, you probably know those better than me.
Yeah, there's some some projects or some research I looked at recently, and it said that probably 1/3 of the people, change of communication, 1/3 of the people that were CRMS turned into CF. 1/3 became carriers, like their practice was played out, and 1/3 stayed at the CRMS, turned into CFTR related.
And we may see if we follow patients longer, again, we haven't been following patients with this diagnosis long enough to necessarily know what may happen to those that stay in that intermediate way into adulthood, right?
Actually, yes. The paper that said that they converted into CF, they were up to 6 years. So it took that long. And so you can see it, but you're not going to see CRMS if you're not doing newborn screening. You're going to see more of the CFTR related as they get older. You have expansitis, polyps, colonitis, pseudomonas, and they're not immune deficient, things like that.
Treatment of this patient?
So for CFTR related disorder, there's not a specific protocol. You're really treating whatever that clinical entity is. So if it's bronchiectasis, you're going to treat them.
There is nothing prophylactic to prevent the progression of
Really, because again, each clinical entity is really very different. If you have congenital absence of mass deferens, there's really nothing you can do at that point other than, change your ways of working on the fertility.
I'm just concerned with the patient for 9. The patient is for
Right,
the morning.
so that's, you want to take it? Go ahead. So that the patient, if CRMS patients are colonized with pseudomonas and we know they are CRMS or there's no other, like they're not immune deficient or whatever, you can use the same protocol where you're giving them the garamycin, cases for 1 month, 28 days, and then let them follow it up. The same, yeah.
Any other questions?
هو بالنسبه للشكل التجميل في مصر في حالات سيمبتومز نسبه لغايه يعني لا مصطلح سيدي وايت الطلب بتاعنا النظاميه معظم الحالات كده المشكله برضه في التجميل بتاعتنا حالات بتكون السوشيال لازم نحن شويه خايفين مع التأمين بيتم مجاني حوالي 300 البول السيكونس المفروض عليه يرفع عليه فقط لا
بص انت هتعتمد على ان عندك سكوير كلورايد بوزيتيف في مره البنات مش قادر تعملها بس التكنيك بتاعته الاول صح ولا غلط؟ يعني انت عامله ازاي؟ هل انت شغال فين؟ لما ايه؟ بتعمل الحالات فين؟ ده من اسكندريه ولا في مستشفى موجوده برايفت بتعملها يعني المفروض ان هي معمل الدهانات البرايفت ده بيعملها صح. فلو انت عامل الطريقه بتاعتك صح وعندك البرزنتيشن او الكلينيكال سيرفيس بتاعتك صح وعندك البيشنت الجينيتك اناليسيس عشان فاينانشال ايشو معاك، اعتقد ان انت ممكن كونسيدر ان الحاله هي بتاعتك سي اف لغايه لما يبقى جينيتكس افيلابل عندك. والتو ميثودز اللي هم بالستاندردايز تكنيك Like your right can see 50 is a positive test. You have 2 positive tests. One is 70 and the other is 50. These are 2 positive tests. Okay. One is vein test and one is a positive test. If you have clinical symptoms of CRMS dysfunction, like the patient has recurrent respiratory problems, and glucose failure and malabsorption, you can also resort to حاجة زي اللي هو الإلاستيز. Maybe if you have a normal
So yes, that might be a milder, yeah, but yeah, still, just make sure there are symptoms to go with it. So the sweat test is the gold standard, so that's really more important. I mean, we all want the mutation because we have per capita now, but this, to diagnose CF, we have the sweat test. And if the patient typically is normal and you have 70 something and 50, that most
أكون البيت أعمل solution
عمل ايه؟
solution في السكول وصلنا البيت
أها.
ما تشخصش يعني هو مش لأن إحنا عندنا البيت مش مرة يعني يكون حاجة تانية يعني.
Right, so there are 17 different reasons why you would have positive sweat in non-CF patients. So you have to go through the differential here. That's why to diagnose CF sweat test is not enough. We have to have clinical symptoms. So the clinical symptoms is respiratory disease, GI disease. If you think that your stage is normal, then that's fine. Then it's not GI issues right now. But respiratory, if you have pneumonia, if you have like, so you have to have symptoms. Yeah, if you don't, then you have to figure out one of the 17 different ways that give you a positive. There are 17 different reasons, so look it up. Okay, I don't have. Yes, sure. Laura, you want to say something?
Oh,
Yes, okay.
Your talk, if you want to share, do you want to share your VDs and your experience with us?
Sure. Like what? Yeah, I can say some.
Something that
I
you
can
want to
say.
do.
I can say some parenting stuff. I don't know
Yes.
if that's helpful. If you want, sure.
5 minutes?
Yeah, less than that.
Okay.
It won't-
Okay.
Yeah.
All right. So we can go.
Yeah.
All right. So Laura Burnell is a dear friend of mine. I knew Laura since for how many years now?
30 years.
Only 30 years. So, you know, she has 2 girls, beautiful girls with CF, and she actually transitioned from the center that she was at. She came to us with open arms, towards me, took her, and she is a reporter, and she really got so involved in CF that she created a foundation called the Bonnell Foundation. She brings in, she helps patients with CF, give them grants to help with education, help with health, a lot of things like that. And this is the second time in Egypt, and every time she comes in, she really enjoyed the culture, the appearance. She speaks English, a lot of the families speak Arabic, they still communicate a little how, but it works like magic, so we're blessed to have her with us.
Thank you. And it is one of the biggest things that I say to parents here in Egypt is we're one big CF family. I can connect with a CF mom even if we don't speak the same language. We get the tears, we know we're going through exactly the same thing. I think as doctors, one of the biggest things I would say is my daughters love Dr. Nasser and they never wanted to leave pediatrics. They wanted to stay with her and they begged her. And they still would go back to her pediatric clinic, and Molly's 30 and Emily's 27. So they do love her, and just know that you are part of our family once you become their doctor. It's really important. And my relationship with Dr. Nasser was really important because I might be the parent that you dread. Because I always wanted information from Dr. Nasser, and I always wanted her to tell me how long they would live. And last time I was here, that was why I was crying when another mom was saying the same fears I had. And I remembered when I was in the clinic with Dr. Nasser, and I was always crying. How long are my kids gonna live? Because in my mind, I'm like, they're gonna be dead before they're 19. And then when I spoke here and parents in Egypt were losing kids before 8 years old, it made me so mad. So I think one of the biggest things as doctors is it's really important to have a good relationship with the parents. I know we can be overbearing sometimes, but I think that's our fear. We're scared. And so that was one of the best things that Dr. Nasser did, was just by hugging me or answering my crazy questions, because it made me feel better. So that was really important. And then you're also trying not to scare your kids and ask questions, because they have questions too. And then one of my daughters had more fear than the other about cystic fibrosis. So that was important to know that this is how she's going to react at an appointment. She's going to run down the hall. She doesn't want her blood taken. You remember when she used to run down the hall screaming and hide in the corner when she was 5? So it's just learning how each kid goes. But I would say that all of these doctors here really helped by working with us. My husband would sit there and he didn't have a care in the world. He didn't, he was like, yeah, it's fine, and I was always the question person, which I think is kind of the way moms go. But yeah, I think that is really important. I think I so love all of your passion and that you're learning all of this for the families here. I do talk to everybody that I met last time on WhatsApp, and I love it. And one of them actually came to the United States, which was delightful. But yeah, if you have any questions, you can ask me now. But I wanted to keep it short. But I think communication is the best thing, or even saying to a parent, because I'm sure Dr. Nasser has said before. Actually, I know she did. I know you guys aren't doing your treatments to my girls. We don't have to lie at every visit. You didn't do your treatment. Let's just say we didn't do our treatment and then move on. And Dr. Nasser had different ways of getting them to do their treatments and feeling like they had some kind of success, and then being able to do medications in school was really important. And raising awareness and talking about cystic fibrosis within the family and other families was really important. But the most important thing for us, the girls and my husband, was the relationship with the doctors, the social workers, the nurses, and the staff. So that was, and the RT, everybody. It's great. And my girls are doing great. Molly's 30. She lives in England. And Emily is 27, and she lives in a state in the United States in Illinois. So they're both on Trikafta, and they're doing really well. They run, they're athletic, so they're doing great.
Great.
So any further questions?
I just want to make a comment. I learned a lot from my family. So, when Laura comes in and she has a million questions, and some of them I don't have answers to, but I learned from, we all, most of us are mothers, and, we, like, I put myself in their shoes. So it is very important to remember that, yes, that parents that sometimes come in and keep asking questions, they're not just annoying, they want to know, they care. I mean, it bothers me when parents come in and they don't have any questions. It's like, right, I have questions, why don't you have? So yeah, and also to work with your patients, especially teenagers, which I love and adore, to make sure they do their treatment, because a lot of the time they're not.
Any other questions or comments? Okay, so I guess this concludes our first day from the workshop. I would like to thank Tanya. I'd like to thank Amy, Laura, Sharon, and Fanny. I would also like to thank my team, Laura,